Welcome, everybody. It looks like a small group this afternoon, but before we begin, I want to make a note of the fact that this meeting is being recorded and will be available for viewing on the Judicial Branch YouTube channel. And we're going to call it to order at 2:07. And everyone should hopefully have the agenda and the minutes from the March 8th meeting. Are there any questions? I don't know if let's see, do we have a quorum? I don't know if we have a quorum. 1, 2. Linda, I don't think we have a quorum. I think we have 5 voting.
I'm on my phone because when I'm on the Teams through the computer, I have no sound.
Okay. So I have 1, 2, 3, 4, 5 voting members.
So then I think we have to wait.
Yeah, because we need a quorum of 6. Okay. So what we will do is we will hold the March 8th minutes until the July meeting. And I will ask you all to, if you haven't had a chance to look at them, if you could take a look at those for the July meeting, and then we will vote on those at that time. So what we're going to do today with the Safe Advisory Committee was we're actually going to do something a little different. One of the things about advising is that you can't really advise if you don't really have the background or the context of a thing. So today was, it's Linda's last meeting. When we join again in July, Linda will have retired. And so we really wanted, while we still had her, to do a retrospective review of the SAFE program. And Linda, are you ready for me to share my screen?
Yes, I'm still hoping beyond hope to be able to get this through my computer, but it's not working. So, hi, everybody. So I go ahead and I'll follow your lead, Denise.
Okay, so I'm going to share, let's see if I can find, and I'm going to apologize in advance. There's a number of things up here. I am actually looking, that's the budget.
Right, Denise, while you're doing that, let me just kind of start the remarks and then
okay, you just go ahead and start the remarks because I need to go find that that fact sheet. Thought I had it up, sorry.
No worries. Hi, everybody. It's certainly nice to see those of you I can on the phone. As Denise said, this is my last meeting, and it's interesting to have had this assignment from her to kind of look back through the history of this program at my last meeting. So I've actually had some good times going back through very old notes, seeing names of people who I hadn't thought of in a very long time. But this work really was initiated, the work to create a SAFE program, I should say, was initiated by excuse me, the Alliance, which was then known as the Connecticut Sexual Assault Crisis Services. And the reason that they put together a program development meeting was because in the early aughts, we had really seen across the state a diminishing of the number of hospital-based SANE programs, SANE or SAFE programs that were there. It wasn't uncommon in the 90s for hospitals to have their own programs in-house, but for various probably economic and both in human resource reasons, I got to get out of this. This is too confusing. Sorry. Those programs were stopped, and By the time this group started in 07, the standard of care for a patient who presented for sexual assault at an emergency department was very, very low. CONSACS was hearing very vocally from victims that they assisted and from their advocates themselves that something had to be done. So in 07, CONSACS put together a group of individuals representing the Division of Criminal Justice, the Forensic Lab, Connecticut Hospital Association, Permanent Commission on the Status of Women, Children's Hospitals, CSEPT, and we were brought on, OVS was brought on maybe 3 meetings into this to really look at the idea of how to create a statewide, state-funded regional on-call SaneSafe program for adult and adolescents. So this work really began, the initial meeting, I should say, was September of 06. So from that point on until the legislation was passed in 09, there was a very laser focus from this group to get a program up and running. So
there you go, Linda.
Oh, thank you. So one of the tasks of the planning group was to determine how many ER nurses in the state were trained and, excuse me, and who were providing services to patients who report for sexual assault. I just realized the error of my ways. My phone is propped up against my water bottle, so I apologize for having to open this. And the survey was really the basis of all the work that Denise and I did early on. So the findings of the survey came out in January of 08. And the survey was distributed to 70 nurses, emergency room nurses, and members of the Connecticut IAFN. So of the 70 individuals who received this survey, 52 said that they were interested in participating in an on-call statewide regional coordinated SaneSafe program. Of that 52, 39 were trained as SANES. And then of the 39, there was a variety of different hours and how they would be willing to be on call and how many times a month and how long they were willing to drive. So the work of the coalition, once we had this baseline where we thought there were 39 individuals who were willing to join this effort, the switch was to look at budgets and legislative language. My notes show that we had 3 very, very strong legislative proponents, which helped usher our work along. And we were, through my minutes, I realized that the Office of Victim Services was one of 3 state entities that were being considered to house this program. As it turns out, we all know where it landed. It came here, and I will forever be glad that the legislation placed it with us. There was always, as those of us who've managed programs or built programs, we know that one of the major issues is always funding, and that was also up for a lot of debate. So Denise, I was actually trying to catch up with you. If you could go back.
I'm sorry.
That's okay.
Oh yeah, I'm sorry.
That's
My
all right.
apologies.
No worries.
Sorry. We are definitely having technical difficulties today. My apologies, everybody.
Denise and I, because of everything that's been going on, we haven't had time to coordinate this presentation. So I appreciate everyone's patience. So what Denise had up first was the very first fact sheet. we had, there was the Senate bill that created the program, which was at that point back in 09, Senate Bill 243, and that concerning the establishment of a sexual assault forensic examiner program. You could see back then, I mean, if Denise can show it.
I'm about to put it back up. It's just this thing won't. My apologies, but basically they're only allowing me to save so many at one time. So
well, I'll just continue. So
yeah,
the original for this program was $275,000, which is pretty much still what the operating budget is. And it laid out that it should be a 24-hour program, that my initial notes said within the first year of passage of this, we wanted to have be responding to 5 hospitals. It developed the plan for regions, although it didn't articulate which regions it would be in. It listed the benefits of a SANE SAFE program, first and foremost for victims of sexual assault, to provide them skilled individuals to complete the exam. They talked about this, fact sheet talked about the decrease in wait times for patients who report sexual assault. They talked about the utilization of money for this program would be the most efficient way, cost-efficient way to provide this care. And it also talked as science evolved, having a trained cohort who understood the kit and all of the elements of the kit could only further the keep pace. Was the best way to keep pace with the changes in the in science. It did go on to show that we modeled this program totally after the Massachusetts model. And early on, when Denise came on, I know we had at least one, if not a few, meetings with them to begin to really understand what they were doing. So this fact sheet was distributed far and wide. It became the talking points for all advocates, from the sexual assault advocates. It also was used by me as a easy to consume document to begin to explore these issues with the judicial branch. In January of 09, the Alliance reached out to our external affairs to begin talking about the potential of using, there's a fund that we administer mainly for the compensation program. It's called the Criminal Injuries Compensation Fund. And the initial thought was to fund this program through that. While this, and I know it's something that Denise is going to show, she has it, this public act numbered as Public Act 0903, when it really is September Special Session Public Act. So it came in obviously at the end of it came in during a special session. The governor signed it, and we were ready to begin this journey with what we thought were 39 individuals who'd be ready to join us and already come out of this gate staffed what we thought was appropriately. At the same time that this was happening, the Division of Criminal Justice had been responsible for reimbursing victims of sexual assault and the hospitals for the cost related to the kit. And the Division of Criminal Justice was also reimbursing hospitals for the cost of any additional care that was required by the patient who reported sexual assault. We were also in 09, that responsibility was moved to the Office of Victim Services. So as of, I think, November of 09, we became responsible for the forensic evidence collection line item, which is about $1.3 million. And that became the funding stream for this safe program. So the funding of this program, what's in the forensic evidence collection line item is reimbursements to the hospitals for that $900 per kit, reimbursements to multidisciplinary teams and child advocacy centers for the work they do on behalf of victims of sexual assault, and the CT100s, the sex assault kit, is also the expenses related to those they come out of this line item. So before we had that line item, we were very fortunate to have violence against women funding and just JAG funding. Drawing a blank on what JAG means. Sorry, Justice something or other grant.
Justice Assistance Grant.
There you go. Which funded this program for the first 2 years, which is why I think in part when I go back in the history, everybody who came onto this program was had to complete an MOA or an MO alphabet soup, complete an RFI to become this program, because none of this was state funding. But under VAWA and JAG, we were very fortunate that if those of you who were around back then know that we were able to provide the participating hospitals with GynoCart, alternate light source. We used the camera system back then. So all of that money, in addition to paying for the safes, the training of the safes, and the coordinator, all came out of that money. And we rolled over to state money, I believe, in 2012, if not 2013. So that is kind of the very the background. I feel like I'm missing something. Denise, what am I missing?
Would you want me to go ahead and let me see if I can stop sharing this one and see if I can share any of the others. Because that was the fact sheet.
The budget was. Go ahead.
Yeah. It's let me get out of this one. Close current tab. And this is the budget I'm going to show. If I can pull it up to desktop.
So the budget was a very simple line items, and when I've looked at it earlier today, I was curious on why we had set the on-call rate for $6.50 per hour. And then again, I was going through my notes, and that was the on-call rate apparently CCMC was paying at that point. So we took that, and I'll be honest with you, I can't read it, but that's what we thought was the minimums to start this program. We had also worked partly with this grant money to enter into a contractual arrangement with Quinnipiac University. And again, for those of you who've been around through this time, you know that they were our initial trainer, that we paid them to bring folks through the classes, and then we took over once the didactic had completed. We had made arrangements for their clinical training. So, and also in this was the very first SAFE Advisory Committee. Our inaugural meeting was 11 November of 2009, and that committee sunset after 3 years when we feel like we had accomplished what we needed. And then as this program evolved, Denise and I really realized that the advisory committee was extraordinarily important for the program to have, to get thoughts, comments, and opinions and discussions from our stakeholders was something we had been missing in those middle couple of years. So again, 4 years ago, this group was reconstituted, and you've been with us through all the changes in the last 4 years. So, so is any questions on what I just kind of provided? Not kind of provided, what I just provided.
Let me just show the survey real quick, Linda.
Okay.
So this was the 2008 survey where the original numbers came from, that we thought we were going to actually have to start the SAFE program. You can see that there was a poll. And I was actually still in school at this point. I was not involved. I actually did not become involved in this for almost a year and a half later. So this was going on at a time when I was not at all involved and didn't know about this, in fact, for some time. But you can see that they were like time willing to be on call. You can see most of them, well, 12 hours with a very close on-call time, which is our current requirement, is 24 hours. Times willing to be on call. They varied. I don't think self-scheduling was on there, which is what we do. And length of time willing to drive. And you can tell this was under an hour. Everybody was thinking this was going to be under an hour. And you notice that not everyone was trained who showed an interest. This was actually just to ER nurses. So those were the, I'm going to stop sharing this. Those were the, as Linda said, those were the very beginning days. There's a few other things that I want to share. When I came into this, I was invited back in 2009. I was serving as the chapter president for the Connecticut IFN chapter. And it was in that role that I was actually invited to be a part of this. And one of the things that I have, and I just want to kind of read a little bit of this, was interesting because I kind of inherited, if you will, some of the testimony. The testimony is on behalf of the legislation. It's public forum. So I'm just going to read, and it's so interesting because it's like a little bit of a time warp, because what was true back in 2008 and 2009 is actually still true. This, and I'm not going to name names, but basically this was dated March 3rd of 2008. And it says, and reads in part, Connecticut IFN is part of a coalition which has been meeting since the end of the last legislative session, and the coalition's sole purpose has been to come up with a design and implementation plan for a rapid response approach for victims of sexual assault. The coalition, from its first meeting, realized a different approach was needed. The members are in total consensus that a state-funded rapid response SAFE program is the answer, as it will improve care for both victims and other patients and emergency department staffing and patient flow. We also believe the program is best implemented through placement into an existing state entity, such as the Office of Victim Services. And back then, apparently, this is where they thought it was going to come from. The funding was going to come from the Criminal Injuries Compensation Fund. And then another, that same time frame, this was another piece of legislation, and I thought there were some really good points that were made in this. It says most victims of sexual assault in Connecticut who seek care will go to their local emergency departments, and the state of Connecticut has proactively provided a standardized kit to collect forensic evidence for sexual assault victims, a standardized kit to collect toxicology forensic evidence for drug-facilitated sexual assault, guidelines for care of the sexual assault victim, and reimbursement to hospitals for the collection of forensic evidence. Yet the system is not complete. One of the most challenging types of patients for emergency department staff is the sexual assault victim. Emergency department staff prioritize care to patients with life-threatening injuries first. And although some victims of sexual assault have life-threatening injuries, most do not, and therefore are not a priority and wait for care, sometimes for as long as 8 hours. When care is provided, it may not be fully appropriate to the needs of that patient if it goes forward for prosecution. Emergency department managers struggle to keep nurses and physicians trained and up to date with patient care standards. It is a bonus to have trained safes working in department, but even with that, they're not always available when a sexual assault victim enters the system for care. And this particular writer writes, I have participated in establishing 3 Sane Safe programs sponsored by 3 different emergency departments in Connecticut, providing immediate access to a safe for each sexual assault patient. One program is currently in place, however, the other 2 have dissolved. This has also been the experience of other emergency departments in Connecticut who have set up similar programs. The programs are difficult to sustain. With natural staff attrition, some of the Sane Safe staff also move on. On top of this is the ever-challenging nursing shortage, in addition to emergency department overcrowding. Smaller hospitals also have difficulty accessing enough staff in their departments or hospitals to develop a program. In my experience, the measures of a successful program include the following: timely access to an examiner at all times, expertise in medical nursing and forensic care, including the most complex patients, meeting all standards of care as defined by IFN, and patient satisfaction with care and increased prosecutions. And then it talks about the return on investment for the state. A couple of emails from that was all in 2008. Now in 2009, as Linda noted, they had this coalition and they were looking at, you saw the budget was $275,000. So this email, which originated from Consax, back then was Consax, on dated July 31st, 2009, said, Dear coalition members, while a final budget has not yet been voted on by the legislature, the Appropriations Committee approved a new budget yesterday, and that budget removes the $275,000 in SANE program funding from the Criminal Injuries Compensation Fund. The document notes that federal stimulus funds will be used for the program and goes on to say that this was not unexpected. And then in a follow-up email dated September 11th, 2009, Dear coalition members, good news. The State Office of Policy and Management has announced certain projects that will be funded with federal stimulus money. A list of planned statewide Justice Assistant Grant projects and statewide Stop Violence Against Women projects includes the establishment of a sexual assault forensic examiner's pilot program, Sane Safe. The anticipated start dates for these projects are between October 2009 and January of 2010. And so basically that's what happened. I kind of came on and, this was being overseen by a grant. I was hired in August of 2010. I was not the first person hired. I came on thinking that we had all these nurses. We had, I'm thinking, as I understood it, because I was sitting on the SAFE Advisory Committee at that time, and my understanding was we had maybe about 40 to 60 to start with, and we didn't. I came in, and the person that had been in my position before me had left, had resigned after 2 months, and it had already left. So I did not have actually a transition time. There was no report. Usually you get a report from somebody or there's some sort of transition, and there was none. So I had to come in and find out. I found out there wasn't anybody. So what we did was I went to Quinnipiac University. Quinnipiac was at that time, they had been contracted as the trainer during this grant. So I went to Quinnipiac and we enlisted a lot of help from a lot of community agencies and scoured the state for who was going to staff this program. And so we found 8. We found 8 nurses willing to be on call. And we actually seated a class of 12 through Quinnipiac University. And there was a lot to develop during that time. I was an ER nurse. That was my background. I didn't know anything about administration. I did not know anything about memorandums of agreement, so I have to tell you, it was a very steep learning curve. And so I 3 weeks into it, I was working on memorandums of agreement with the hospitals that had already been chosen. There are 6 hospitals that had already been chosen. And Linda, you can correct me, but if my understanding is correct, they were based, those 6 hospitals were based on relationships with advocates and billing. Am I missing something there?
No,
I thought it was just regional to Hartford.
I'm sorry, what was that?
I thought it was with the proximity to Spring Street, wasn't it?
No.
Kind of. No, okay.
No, it was, we took the then Consac's lead and looked at the hospitals that they enjoyed the best working relationship with, which is how we identified those hospitals.
But it was kind of circular to where Consac's was located at the time. I mean, we didn't, it was not picked randomly in the end. I think we really did end up being pretty regional to the Hartford area.
But I think when you look at the programs that had the best, yes, you're right, they are in the central region.
So with that, basically there was, I learned all about, and I lived it for about 3 years, memorandums of agreement, negotiating with hospitals, developing an activation system, developing a scheduling system, working with the equipment, and just building a basic infrastructure. And the grants were time limited, so we were on the clock. Of course, there was always all the requirements of a grant that you have to provide, which are the numbers. And I would always have to provide those on a regular basis. We also began to see issues. For instance, the issue of unconsented, unconscious patients came up. Minors came up. I still remember a conversation in the first SAFE Advisory Committee where we all agreed that what happened with the SAFE program was that it was kind of starting to highlight and shine a spotlight on some of the issues that were out there, but just nobody really saw them. So that was kind of sort of between 2010, fall of 2010. We did get up and running on December 4th of 2010, finished that class of 12. We started precepting them. We actually initially started, it was Thursday morning to Monday morning. We were not 24/7, but we were having such difficulties actually getting people precepted that in April of 2011, I went to Linda and I said, you know what, we have to just simply do it. We have to just do it. And so we went 24/7 and I will never forget those days. I will tell you that. But I learned probably more in those 2 to 3 years than I ever learned anything about this field of work. But in 2013, the thing is the grant was time limited, so we had to get it out of grant funding and we had to roll it into the judicial branch's budget. And the judicial branch had to agree to that, which ultimately they did. We also at that time had to develop a training program that was accredited, or at least met the standards. At least it wasn't accredited at that time, but it needed to meet the standards of the International Association of Forensic Nurses. So we actually brought in the then president of IFN, Polly Campbell, who was the state coordinator of Maine. She actually came in to Connecticut and helped develop that training program, which was in the fall of 2013. And slowly, we actually began to grow the program. We finally got to, up through 2015, we got to a point where we could actually think about expansion. And so in 2015, we moved towards a Western expansion that would include Yale, St. Ray's, which I don't think was part of Yale at the time, but St. Raphael's. It included Midstate, Bridgeport, St. Vincent's, and we talked about Griffin. Unfortunately, what happened in 2016, as we were developing the MOAs, we were getting them signed, we actually posted for a regional coordinator. But during that time, the state budget was beginning to struggle, and in 2016, there were major budget cuts. that impacted the program. And so we lost that expansion. We had to withdraw the expansion. We had to, we actually, Linda referenced a camera system, the Secure Digital Forensic Imaging System, SDFI. We had that camera system. We had 7 systems and one for training, one in 6 hospitals. We had to put an end to that. We also had to withdraw our regional coordinator position. It was a devastating blow. And I will think that it forever actually changed the course of the program. So in that time, in 2016, after we lost it, we were left with, what we were left with was we did add 2 hospitals. We had already signed with Midstate, so we kept Midstate. We also signed with Connecticut Children's for 13 and older. This was largely because they had been transferred across the street to Hartford, and their legal department had a discussion with us about the need to include them. And then it's beyond the scope of this meeting, but we also added the University of Connecticut Storrs campus to our response. So that was 8 hospitals and the University of Connecticut. And so that was in 2016. So we began to build from scratch all over again. But the thing is during that time, we felt that there was a lot of issues with only having a standard of care in these 8 hospitals and nothing for the rest of the state, because by statute, the only people who could train as safes were those coming into the SAFE program. So the judicial branch and the legislature agreed, and so Public Act 1799 was passed. Although it took it, you can pass a law, but you have to also develop a way to implement it. So that meant developing new memorandums of agreement, this time for non-participating facilities. And so the first class that we seated under that new law was actually the fall of 2018. And what we quickly learned throughout all of this time was that people wanted the training. People wanted the training. They did not want to be on call. And that made things very, very difficult to really to build the program, to expand it. And that became very apparent when we began to bring in staff from other hospitals, non-participating hospitals, to train as safes. But we were trying to maintain some consistency. We had initially used our quality assurance meetings where we had speakers. They were not CEU, but it was, continuing education. We had initially limited that to those in the SAFE program, but in 2018, realizing that, the whole purpose was to create a consistent standard of care. So we began to invite those who were not a part of the SAFE program to attend the QA meetings where we had presenters. During that time, though, the International Association of Forensic Nurses developed an online course. It was a great course, but it was also very generic. It was not state specific at all, and it was online. We quickly learned that those, even in this state, who were taking that course, and there were some who were, we learned that they had no idea that the state had a set of technical guidelines, or that there was a commission, or that there was a way that the forensic lab wanted evidence collected. And that began to be of some concern to the state and to the various entities, from especially the lab. So what happened then was in 2019, Public Act, which was our most recent one, Public Act 19114 was passed. And the whole purpose of that, the whole purpose of all of this was to ensure consistency across the state. So it sole sourced us as the trainer for the state. And during that time, we also began to realize that, hey, there's 36 counting, there's 36 acute care facilities and affiliated campuses. At that time, we had contracts, or during this time, we had contracts with, Denise, correct me if I'm wrong, but I think we had contracts with about 24 of them. and it was a lot of work. They were not on the same schedule. And it began to be more work to maintain, to interact, and to try to keep these up to date than it was to actually run the program. And so we looked at hospital system MOAs. So Hartford Healthcare, Yale New Haven Health Systems, Nuvance, Trinity. And there were some hospitals that were still like individual hospitals, Stanford, Middlesex, Griffin, Bristol are all individual hospitals. Even though they may have system after their name, they're still individuals. And so we tried to move in that direction. And 2019 was a busy year. So not only did Public Act 19114 pass, because of the addition of that, we actually were able to create a position for a training manager. And we were able to hire a training manager in the fall of 2019. And so all of this led us up to the point where we're beginning to grow again. We're beginning to actually get to a point where we can look at expansion again. And then the pandemic happened. And of course, we all know what happened with the pandemic. I'm going to tell you that we are not the only ones that lost staffing. Across the nation, SAFEs were lost from multiple programs. It was completely separate and apart from my job as the program manager of the SAFE program. But during 2019, 2020, and 2021, I served on the board of directors of the International Association of Forensic Nurses and served as president during the pandemic. And I don't know which took more time, running the SAFE program and trying to figure out what to do, or actually running IFN, because everyone had, but it gave me a global perspective. And what I quickly learned was the things that we were seeing on a state level were across, we were not by any means isolated in that. Every state saw a loss of SAFEs. And not only SAFEs, but also staffing. This is where a real crisis in the staffing of nurses in hospitals across the nation was created. And so, but we had a good training manager, and for us in the Connecticut, she managed to figure out how to develop a virtual training program. So we were at a time when things came to a stop. She actually forged ahead and found a way to keep our training program going. And I'm going to hit the pause button here. This is National Nurses Week, and the SAFEs in the SAFE program, I am going to share with you that you will not see them featured on Facebook or Twitter or press conference. However, some of those original SAFEs, the ones that were seeded in the fall of 2010, those SAFEs are still with us. Some of the SAFEs during the pandemic, they would be deployed to COVID units, and they came off the schedule during that time. And then when they got back, they would get right back on the schedule. They had been quietly responding to cases for this entire time. And there was one nurse who during the pandemic responded to 77 cases herself, and she was at high risk. So I want to recognize, and I want this to be a part of the record, that SAFEs in the SAFE program are recognized for their dedication during National Nurses Week. So with that said, in 2023, as we move ahead, and we are going to move ahead, we have over the past 13 years done due diligence to fulfilling our mandate and our charge. And with regard to developing a response program that was supposed to be from one side of the state to the other. And I want to share something with you. I don't know if I can bring it up. Let's see here. I'm not really seeing it. What I want to do is I will share it with you. If I can't share it with you on the screen, I will send it out, because basically it's a visual of the 36 hospitals and affiliated campuses and how many are actually under MOA with the judicial branch, mostly for training, some for response. But this is the response program for the state of Connecticut, and it is the SAFE program for the state of Connecticut. And I wanted to share with you that even though it doesn't look like it, we actually have, I went back and counted from the fall of 2010 through spring of 2023, the class that just finished last week. I'm going to give you the numbers. We have trained a total of 463 SAFEs in the state of Connecticut over the last 13 years. Of those 463, there are currently 165 who are eligible to practice as SAFEs in the state of Connecticut. 30 of those are in the SAFE program. And so the task ahead for the SAFE Advisory Committee is really to look at this from the perspective of, okay, so the statutory mandate is a response program. How do we accomplish that? And there's also other things that the SAFE Advisory Committee is going to need to tackle. One of them is hospital education. A couple of Saturdays ago, we were doing a clinical training day. We had SAFEs there from Bacchus all the way over to Greenwich. And largest class we've ever had, largest clinical training we've ever done. And but two of those nurses from a single hospital came to me and said that their hospital was sending them to train as SAFEs, but that they were not going to be allowed to practice as SAFEs because their hospital's risk management viewed it as a gray area. We have, yes. Oh, yes, I see Sherry's face. Yes. IAFN has been here in this state, and I've had conversations with some of the folks there, some of the educators there. They have been here to train. They are of the viewpoint that Connecticut does not know what the role of a SAFE is, and I would concur with that, largely at the provider level. Most of our SAFEs that we train are not doing speculum exams. I can tell you that for a fact. They are not, and their hospital policies do not cover them for the role of SAFE. So the SAFE Advisory Committee really needs to look at how to address hospital education as well as expansion. And those are just a few of the things that are on the plate of this advisory committee. For anybody that does not know, I will be chairing this committee. Just 1 second, Rachel. I'll chair this committee for about 3 more meetings, and then in January of 2024, there will be a new chair. Because as Linda is retiring, I will also be retiring. And but the work ahead continues. Rachel, you had your hand raised.
Yeah, I just had a question to confirm. So in 2019 with Public Act 19114, and that granted you guys the sole responsibility of education for all programs within the state. Another huge burden. When you talk about the program, who are you using, just so everybody knows, and what do you think your needs are in OVS to maintain the responsibility of not only expansion in a statewide response program, but being able to provide all that education in a consistent and timely manner while updating program training and things like that. Right now, you have yourself and a training manager. How is OVS meeting those responsibilities currently, and what do you feel that you would need in the future to continue to meet those needs?
For training needs, I think that we are meeting the needs. As Denise Poncini, our legal representative, the those who are able to attend are those who have memorandums of agreement. I will say that Nuvance is in the process of signing theirs. We hope and are looking and working with them to get theirs done in time for the fall class. And that would put all but 4 hospitals under us for meeting the training needs of. So far, we've not turned anybody away, nor have we needed to.
Well, I thought, but can we clarify though? I think there are times when you've limited the amount of people per facility in a class though, right? I mean, so in theory, you could have more people in class if you had more precepting. I think it's the precepting, I think that gets you in trouble, right? So you try to limit the amount of people per class, so that sometimes has prevented some people from taking the fall class when they want to take the fall class, because you've already allowed one hospital to send 2 other people that you've accepted. Isn't that correct?
No.
Okay, because I thought you've told me that before, that you've had to limit.
Well, what we've done is
in the class.
What we've done is we've given 2 people per hospital per class. And what we've found is that we've never had hospitals overfill the class. Most hospitals, we actually are trying to get people, particularly those who have fewer safes. The priority has been those who are coming into the SAFE program. And that's always been the priority. The second priority are those with few or no safes at all. And what we find to be true is that there's not ever been a time when we have had to say, no, thank you. In fact, we actually had 3 nurses who applied for this class, this spring class, whose managers pulled them. What we're finding to be true is that hospitals are not sending who probably should be sending. That's what we're finding.
Probably because they're still struggling on their own staffing, is my guess. And, it takes them away from their day.
Yeah.
So, that may be a bit, but but in theory, I'm almost getting a little bit back to what Rachel was saying, as far as what you need. Haven't we discussed in the past that maybe if we had more precepting options, we could expand the class sizes? Or
no, precepting is solely for those who are in the SAFE program itself.
Oh, we don't send the hospital folks through that?
No, we don't have contracts with them. Denise,
Denise, Mariel may be confused. We do the clinical. So if a hospital sends a healthcare professional, they get the didactic and they get the clinical. They get the mock exam, they get the evening, and so they get all of the clinical. The precepting piece is when they're dispatched to a hospital, and then there's a SAFE that's in our program and an experience SAFE. That's what the precepting piece is. But any hospital that sends their medical providers gets the 41.5 hour didactic and the 3 elements of the clinical.
And so, okay, so Linda, I think what I'm getting is, I thought in the past we've heard that the clinical placements can be tough. And if we had more options for clinical places, could we expand class size, or is that not the case?
It's a valid point, but right now that's not a problem. We actually have a wonderful clinic. I can't say enough good about them. They went out and bought equipment for us. They've expanded. We have, I forget if it's 16 or 18 exam rooms available to us per Saturday. We went from 4 exam rooms pre-pandemic to 6, and now we're up to 8. We have enough for 10 at this point in time, and we actually have, I would say, more than that if we really needed to. We have the trainers. I have models that I'm not using right now, but who have basically completed the paperwork or have the paperwork and have indicated that they want to do this. So I don't think at this point in time that's an issue. It hasn't been. I will tell you it's a lot of work. Now, Rachel, you had your hand up.
Yeah, thank you. You and I had spoke before because I believe you actually said to me that you had to turn down not for your hospital contracts, but individuals who personally wanted to attend the program. So nurses within the state who may not have an MOA, that you're no longer accepting applications from, say, individuals that would be willing to pay for themselves to go through the Connecticut State training program that may not be associated with a hospital. And then the other thing, to speak to what Marielle was saying, was I'm glad to hear you have more GTAs, but I do know that in the past, I definitely feel that you were saying with the GTAs and having to do 15 speculum exams per a class of 36, you're talking about repetitive speculum exams on the same patients, that becomes a problem with numbers when it comes to how large the class sizes are going to be. So, and then
Go ahead. I'm sorry.
that's okay. Are we using the nurses who are the respondents in the program also to be your clinical instructors and also to be the teachers for the program? That's an additional burden on that same group of nurses. Obviously, they're the experts if they're responding everywhere. But is there any options for making more full-time positions? Because it feels like your needs are greater than what you have approved for right now.
So I'm hearing three things. So the first one, correct me if I'm wrong. You're asking if there's a limit on the nurses who can be in the class or become safes. So number one, they do have to be from a hospital that has a contract. We can't just, if somebody works that is not from a hospital that has no contract, we're not able to accept that. And that is something that our legal department has stipulated. I don't know, Denise.
Let me just can I clarify though? So if they wanted to work for the SAFE program, that would be different, but they'd have to have a specific background. But if they just want to get trained, but they don't want to be on call through the SAFE program and they don't necessarily work at a hospital right now, you're turning those folks away from application.
If somebody wants to just simply take the SAFE course, they don't, let's say they work for an urgent care clinic, let's say. They don't want to be a part of the SAFE program and they're not being sent by a hospital that has a contract. Those folks we cannot accept, and we cannot legally accept them.
Because you feel like they won't be ever in a position to do a kit?
Denise, I'm looking to you to kind of clarify this.
That has been, can you hear me?
Yes.
Okay, that's been the position that we've taken, that they have to be through a hospital. Then we have more guarantees of control over the quality assurance programs, and Denise being able to go in and check the records and the control over the kits. So it has never been open to nurses that just want to be trained to use it in other than an emergency department that does not have an MOA with us.
Would we ever consider changing that in the future if we needed more bodies to get trained? Might apply to work at a hospital or might eventually apply to work for the SAFE program? I'm just wondering. I mean,
I think the legislation is constraining, and I don't have it up in front of me right now, but I think it is constrained by emergency departments and the definition of that in healthcare professionals also.
But again, that's one of the pieces, I'm sorry, Sherry, as an advisory committee, if you reach a consensus that should be, that is then a recommendation that is made, approved, and moved to the director by statute to then bring to the chief court administrator.
And just food for thought. It sounds like perhaps there's not a huge crowd of those people, but if we ever get there, it's a way to maybe open up the pool of potential trained people down the line. I agree though with Denise though, if they've never worked at a hospital, they're not going to want to be a SAFE in the SAFE program or, be employed at a hospital ED either. if they've never ever had that experience, I feel like they should still have that experience as in their background, even if they're not doing it today. You know, I can still see wanting to get trained because you've worked in an ED before and you know what that's like, and you feel like having this training might help you get a job in the future, or you might eventually want to work for the SAFE program. But I feel like if you're just a nurse walking off the street who's never worked in a healthcare acute setting, getting trained as a SAFE might not be the first best step of, you know, the next career path for you.
Yes, and also just to tag on to that, and I did clarify this with the Connecticut Board of Nursing. I've had a number of LPNs that have asked about becoming SAFEs, and the Board of Nursing has said absolutely not. They cannot. I tried to get them to actually put something like that in writing. They said the only way I could get that done is if I actually showed up at one of their meetings, made the statement, and got it in the minutes. That was about the only way I could get that done. But Rachel, I think to your second point about the clinical training, the number of speculum exams, you know, that has been an ongoing problem. It's a really good point. It's been an ongoing problem that when you're doing, and even the posters say, you know, 4 to 6 an hour, that the Alliance actually recently put back out not too long ago. It is a lot. And so what we did, and I've had meetings with the models, impromptu meetings after the clinical training day. For this class, we actually worked out something different. And it's sometimes it's like, I call it the Thomas Edison moment, where you fail at something like a half a dozen times, and then you finally find the right way to do it. And what we did was we divided the rotations up between the rooms. I actually did talk, first of all, last fall, I went to couple of sessions on GTAs, medical models, that topic. I also talked to my colleagues in several states, in New England in particular, because we do talk to each other. And what we kind of figured out is if we add more models, add more rooms, it lightens the load, if you will. And so what we did was we went, instead of rotating every 20 minutes, we rotated every half hour, and we went, and it's not a matter of numbers. 15 is that's the old thing. I actually went to, when I first came into this program, I went back to Quinnipiac, where I had initially done my training. I said, what's with 15? What's the evidence-based practice for 15? And they said, well, there is no evidence-based practice. It's just a nice number that they came up with. But clinically, it's developing competency in the eyes of the examiner. And that's the standard that's used. And so what we've done is we lowered the number that was required. And we lengthened the amount of time that the students were in the rooms to focus on the quality of the training. We're really emphasizing the quality of the training, correct technique, approach, that sort of thing, as well as integrating the evidence collection piece of it. And we did this last class with the 8 rooms, and they loved it. The models, I've had compliments from models, love the new way of doing things. They're happy with it. And so I feel like maybe we've found a solution. Even the one model, we had one model who would she kept us on our toes in terms of letting us know when it got to be too much. We also have an understanding with all the models, and I'll just a second, Sherry. With all the models, and they said, you know, it's really good for the SAFEs, the new SAFEs, to also respect this. We call it withdrawing consent. The models, if they feel like they've had enough, they withdraw consent, and the SAFE has to deal with that, and has to acknowledge it, and it's actually good practice for them, and they work around it, and with a patient approach. So so I think at least with this class, I think we have really found a solution. And of course, there's always room for improvement. We're always looking to refine and improve. And the last thing, Rachel, and I'm sorry, I forgot, and I probably, Sherry, I see your hand up, but Sherry, you had one more question? I mean,
Oh, no, I
Rachel.
mean, we can finish this. I mean, and then I'll go back because it was about the last thing, but keep going. I don't want to interrupt the thought.
Okay, Rachel, I think you had, oh, about the trainers. The trainers, okay. We have a number of trainers within the program. We've actually, I went back and counted the other day. I can't remember how many trainings there have been. I can tell you that we've done, we've trained 66 staff at hospital facilities, and I forget, I'm sorry, I don't have the numbers in front of me, but I would say at least 24 in the, maybe more than that, maybe it was more like 36 in the advocacy trainings. They rotate, they take turns. We train them to train. I actually spent some time yesterday and this morning training one of our new trainers. She's doing a training this afternoon at 4:30. We have more who have been added through the RFQ process, request for qualifications. I was hoping to make it simple. It is not. It's like the RFI. You have to apply to be a contractor for the state. And by contract, yes, not only is the SAFE program, in fact, I actually think I have it here. Not only is the SAFE program the trainer for the state, but it is the trainer for all staff. It says the judicial branch, this is an MOA, the judicial branch SAFE program staff approved by the judicial branch SAFE program manager shall be the sole source of training for healthcare professionals from health centers on the care of patients who report sexual assault. Any training conducted in the health centers must be specifically approved by the branch program manager in advance and shall use training materials approved and produced by OBS and shall be in accordance with the technical guidelines as revised by the commission from time to time in relevant legislative updates. And that's really about consistency in training. We do make sure that they train. We have a program I'm going to be sitting in on the one tonight. We have, it's a constant work in progress to try to maintain consistency. It's very, 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 very difficult when you have 36 hospitals and affiliated campuses to look at statewide consistency. And to your point, Rachel, yes, could we use more staffing? Of course we could. But money is, I think it's an evolution. I think when I look back at the 13 years we've been in existence, I think we've come a tremendous long ways from where we were 13 years ago. And the work will continue. And I'd like to see what it looks like in another 10 years. And I do think we will be adding more trainers and more instructors as the program grows. Any other questions? I think Sherry, did you have a question?
Yeah, I was back a little bit, but it was about the legislation about who can do it and if they don't work for a hospital currently or doing the state program. If we change that legislation, just something to think about is that there are a lot of new graduates that are coming in. And though that's something that is there something that we want an experience or it doesn't matter? Because I know when talking to new graduates, especially the GEPIN program, they're older. I'm not saying that's traditional ones maybe, but it's an area that the newer generation nurses are looking to get extra qualifications and certificates, and they might look and apply for this because it is something that they might be really interested in because they have different experiences and something to think about. There's like that untapped, they might not be in the emergency department right away. They might not be in an affiliate hospital, but that is an area that we probably haven't explored yet. Do you need experience otherwise, or is it just for it to being a safe? Because once they get their license, they might be interested because they'd like to get more. Sorry, there's a bee that just flew at me. Sorry, I'm like, oh.
Well, in your
But they
personal
like
space. Yeah.
they just do like to do that. And I know when I've talked to, you know, people at the end of their programs, they're very interested. And, you know, I'm always like, well, you have to go get your NCLEX and get the RN and then see where you work and stuff. So it's just something to think about as an untapped area that we have
So
to be
if-
careful about if we open the legislation or you want to open the legislation
Yeah.
and open them up. So it's just something that we would be faced that if we're not clear with our language.
Yes, I mean, and that's something certainly that the advisory committee could look at. I will tell you to that point about experience and all that. We are getting phenomenal safes from nurses who, you know, from the email blast that got sent out. These are nurses from public health, from hospice, from all areas of nursing, and they are phenomenal. One of the best nurses I've heard nothing but wonderful things, is a male who worked in hospice. And he brings that gentle manner with him. And we have more. Sherry, I don't quite know when you sent out that email. I saw it. For those of you who don't know, there was the Connecticut Nurses Association was in their newsletter. And I think it wasn't in somewhere else, because in the last 24 hours, I've gotten 14 inquiries.
Well, so Denise, that actually brings me up to my one other question before we jump off, and this is the CNA has been put it out twice for 2 weeks. They will send it out again if you want them to, unless you're getting a good response. So it is in their newsletter, and the CCNW is sending it out. I think they were trying to. I just asked them again today, and I haven't heard back yet. Like, have you sent it? So that's still another area that will be sent out. But I think the CNA reaches the more of them than anybody else.
Yeah.
And I can ask her to send it out one more time if you like. But if you're
Sure,
getting
I mean-
14, I don't know what your number goal is.
Well,
so
remember what I specifically said. This was a change for y'all who do not know. The initial one that went out last year that elicited something like almost 300 inquiries was very general. It was not specific for an on-call program. And when they found out it was for an on-call program, now we had a great response. We have 13 new safes, just as in that one class, and we have others in this last class. We had. We actually dropped some. We interviewed 11, but we're down to 5. And mostly because of dates not working out. But in that class, we actually had 5 who completed the class, and then stayed and said, "I want to be a part of the on-call response program." So I really think that this has been a kind of a page turner, and all the better, because if we can front load the class with people who are in the SAFE program, coming into the SAFE program, the easier it will be and the faster we can actually expand.
Okay, great. I'll have her send out another one.
Yes. So any other questions? Okay, because I know it's been a long meeting. I'm kind of looking for my end of these, because it's 3:19. Linda, do you want to talk about the review of charge? Do you want me to?
Of the what?
The review, remember you were going to talk about, and I apologize for processing in front of the group. Did you want to say anything more about the SAFE Advisory Committee? Because we're moving on to number 5 on the agenda, review of charge and terms.
No, I think I'm good.
Okay. So obviously the SAFE Advisory Committee's role is just that. And what this has been about has been to provide some context. Anybody who knows me knows I personally believe, and I just think it's a truism, that if you don't have context, it's hard to understand a point in time. And the SAFE Advisory Committee came to being in a point of time. And it's been a while. It's been 3.5 years anyways, since this advisory committee started. And as I said, the next time we meet, we will, Linda will have retired, and we wanted to, while we still had her and still had all the history that she has, we wanted to take advantage of that and do a retrospective review. The charge is basically contained within, and I don't, let's see, I have it here. 19114. And I'm just going to read this out. There is established a sexual assault forensic examiners advisory committee consisting of, I'm not going to read all of the entities on here, but it does specify which agencies and are represented on this committee. And the point that I want to make as far as the charge goes is under B, is the committee shall recommend to the Office of Victim Services policies and procedures with regard to the Sexual Assault Forensic Examiners Program established pursuant to subdivision 14 of subsection B of section 54-203 as amended by this act and section 19A-112G. Recommendations from the committee may include, but need not be limited to, the following: the certification process for individuals qualified to participate as sexual assault forensic examiners, as defined by substitute Senate Bill number 796. 2, continuing education requirements for the maintenance and renewal of such certification. 3, the development of quality assurance measures to ensure the needs of victims of sexual assault are met. And 4, such other related recommendations as determined by the committee. And under C, any recommendations of the committee made pursuant to subsection B of this section shall be presented to the Director of the Office of Victim Services for consideration. The Director of the Office of Victim Services may forward such recommendations to the Office of the Chief Court Administrator. The Chief Court Administrator, in his or her discretion, may direct the implementation of such recommendations as policies and procedures pursuant to section 54-207A as amended by this act. And then it goes on to definitions. As of July, this committee will have completed 4 years. The terms will be in 4-year terms. And so over the summer, over the next, not summer, but over the next couple of months, we will be reaching out. The office will be reaching out to all the agencies listed in the statute to determine who will start the new term, which starts in September. And these will be in 4-year terms. Any questions about that? Okay. Finally, last thing on the agenda, new business. We have 5 minutes.
I just have a question, Denise, and it stems a little bit from the conversation earlier. With folks coming, if we ever had folks coming from out of state who have been fully trained safe in another state, I don't know if you've run into any frustration from them on, they can't obviously just plug themselves in here, but should we as a committee figure out a way to expedite somebody who might come with a good amount of experience already without having to maybe make them take the entire, I don't know the merits behind, whether there is any benefit to streamlining a process for someone that may come in with a lot of experience who just needs to know key things about Connecticut. So that's just a thought that I wanted to throw out as, a potential thing to think about as a committee.
As far as I know, they do have to take the class. And my experience with those, and we have had a number who have come in from out of state, with no exceptions, they have been taken aback by the differences in the states. They had no idea, and we have several in the SAFE program. We have had others who have gone back to their hospitals. The only ones who do not have, if they come in and they're board certified, this is the exception. If they're board certified, they sit either with me or they do 1 day with the annual competency day, and they're done.
Okay. Oh, so it sounds like we kind of already have that built in.
Yes.
Yes.
Okay. Question answered.
Okay. Any other questions? Any other new business? Okay, so we will adjourn at 3:26. The last meeting in this term is July 12th at 2 p.m. It will be virtual, and we look forward to seeing you all then. Thank you so much for taking the time to
Bye.
attend.
Thanks, Linda.
Thanks, Muriel.
Bye, everybody.
Bye, everyone.
Thank you for
Bye, Linda.
coming.